Good afternoon, everybody. It is a tremendous honor to introduce today's speaker, Dr. Keith Lillemoe, one of the most respected figures in the field of pancreatic surgery and surgical oncology. Dr. Lillemoe led the Department of Surgery at Mass General for over a decade. Dr. Lillemoe's career spans decades of leadership, innovation, and mentorship, including prior role at Hopkins and Indiana University. His clinical expertise in pancreatic cancer, combined with a deep commitment to personalized and precision-based care, has shaped the treatment landscape for one of the deadliest cancers of our time. We are especially proud to have Dr. Lillemoe join us at Human Longevity today, not only as a world-renowned surgeon, but as a longtime friend and advisor who has cared for many of our clients with compassion and excellence. Before Dr. Lillemoe is going to share our talk, I'm actually going to share with you a very short video. And this is actually a client that of Human Longevity, and also is Dr. Keith Lillemoe's client, and Mr. Kim Adelson, and here's his talk. Oops.
I thought, my age, I was otherwise healthy. It might be a good time to take a look under the hood, so to speak. And much to my surprise, I found out that I had a tumor on my pancreas. Thanks to Human Longevity, I mean, I'd probably be dead today. I wouldn't have known anything.
Yeah. So Kim is, after years of surgery by Dr. Lillemoe, he's live and kicking, and it really is in his 70s. And this is really what we're embarking on, how to eradicate these deadly diseases, because more than 50,000 Americans die of pancreatic cancer every year. With that, I would like to present Dr. Lillemoe. And Dr. Lillemoe, please.
Thank you very much, Wei Wu, and it's a pleasure to be associated with Human Longevity. I've been a personal patient there. I've treated patients there. I've helped manage patients with other diseases that have come to my institution, and it's an organization I have the utmost respect for. And so it was a pleasure for me to accept this opportunity to talk about the disease that I've focused on. I'm going to share my screen now. We practiced this already, and I'm going to go here, and I'm going to do this, and I'm going to do this. Are we all good, Wei Wu?
Yes, perfect. Yeah.
Great.
Yeah.
They said I couldn't be taught. So thank you. Thank you so much. I am really, again, pleased to talk about this topic, because pancreatic cancer, as I start out with this background, is not a very fun story to talk about. It's not a fun group of patients to treat. And we just keep looking for small areas of improvement and accomplishment. And I'm happy to say that there has been much accomplished. The future looks bright, but we have much, much more to do. And that's the nature of my talk. I'm going to interject a little bit of personal information here periodically, but more importantly, I want to educate you, the people who are viewing this as clients or people who have an interest in pancreatic cancer, to understand a little bit about this deadly disease and what Human Longevity is doing to try to help make this diagnosis earlier, which is the key to survival. So a little bit of background, Wei Wu mentioned it, over 53,000 patients are diagnosed each year with pancreatic cancer in the United States. It's the third leading cause of cancer death in the United States. The risk factors associated with pancreatic cancer are smoking, certain types of pancreatitis, and some genetic syndromes that are well defined. But there are a lot we don't know about the genetics of pancreatic cancer. and certainly a family history of 2 members of your family with a diagnosis of pancreatic cancer is a high risk factor that should be considered in being aggressive in terms of evaluation. I'm going to share the bad news first. As you look at this data from the National Cancer Institute, these are the trends in survival for all cancers adjusted for age and sex in the United States over the last almost 50 years. And as you can see, at the very bottom of this list is pancreas. The lowest absolute change since 1975 for any cancer in the United States has been in pancreas cancer. And for many reasons, the story is getting worse. Pancreatic cancer, as it started, my first slide said, we're the number 3 leading cause of death in the United States is pancreas cancer. It projects within just 4 or 5 years, pancreatic cancer could be the number 2 cause of death besides lung cancer. And so it is a disease that is rising in terms of mortality. The problem really is with pancreatic cancer isn't that we're not good at treating it, that we don't have good drugs, we don't have good surgery. It's we cannot diagnose it early. 50% or half the patients who present with pancreatic cancer at the time that they are diagnosed present with metastatic stage 4 disease. And in most cases, they're considered incurable. Another 30% present with locally advanced disease. Now, the pancreas is an organ that's based in a very complex part of the body. There's major arteries and veins that go to your intestines and go to your liver that just, I hate to say it as a surgeon, can't be messed with. And if these arteries and veins are involved, surgery is not always an option. So that leaves only 20%, or 2 out of 10 patients who are diagnosed with pancreatic cancer that even have a chance for a surgeon like myself or the excellent surgeons throughout the country or world that treat these patients to have a chance to help. And though these survival data are maybe a little bit old, because we have seen some improvement that I'm going to talk about later, is if you present with stage 4 pancreatic cancer, if you live a year, you're kind of out of the range. With locally advanced cancer that's not operable, again, if you live a year, you're on the fortunate side of things. And even the cases that we celebrate that we can resect and do a big operation and have great outcomes, still, the survival at 5 years has been as low as 20 to 25% in the past. Now, I'm going to talk about some progress that we've made, but still, the results really reflect at the stage at which time people are diagnosed. So this creates a pretty barren background when we talk about pancreatic cancer. And unfortunately, there is a little bit of brightness that is coming, and maybe an oasis in the future. But this attitude related to pancreatic cancer as being such a poor diagnosis has really led to a nihilistic attitude. And many patients are told they're diagnosed with pancreatic cancer, there's nothing that can be offered. And again, there's a message that I would say to any patient, whether it's for yourself or a family member, you need to seek the very best of treatment. Because if you just say, I have pancreatic cancer, it's inevitable I'm going to die, you're going to be denied the opportunity to have things that can certainly be life-extending, both in terms of quantity and quality. And unfortunately, like many aspects of care in the United States, there's social and economic and racial disparities in how we deliver this care. Now, there has been improvement. As I showed in those slides before, 25 years ago, the 5-year survival for pancreatic cancer in the United States was 3%. Our most recent data shows that 5-year survival is up to 8%. So this is truly 166% improvement. But again, there's problem is that we are not getting the chance to intervene early enough because of late detection. And so my message is going to give you a little bit about the background of some things that have improved over the last 20 or 30 years of my career as an academic pancreatic surgeon, but also that are going to make the future even brighter. So what are the reasons for improvement? Well, first of all, there's been better chemotherapy for patients with metastatic disease. And Wei Wu and I had a brief conversation before we weighed in about new tumor-specific vaccines that are on the horizon. And we've seen the role of immunotherapy or vaccine-generated therapy in many cancers. And I think those opportunities are going to come, but they're not going to diagnose the disease early. And so far, the trials have been applied to mainly patients with advanced disease and have been relatively positive in terms of extending life. But when we can use these therapies, particularly chemotherapy and immunotherapy, earlier stages, I think we have a better chance to help. I say in this next bullet is with surgery, which is the ultimate cure for patients with pancreatic cancer, involves surgery in almost 100% of cases. Coordination with medical oncology for both standard chemotherapy and new immunotherapies, either before surgery or after surgery, has made one of the biggest impacts of surgery. And I've been fortunate for the last 14 years to practice at the Mass General and Hospital in Boston, Massachusetts. We've been the leaders in advancing the role of chemotherapy and radiation therapy prior to surgery in helping offer surgery to more patients. And finally, as a surgeon, I have to take a little credit to my generation, the generation before us, and maybe now even the generation after me, for improving the outcomes of pancreatic surgery. When I started, 1 out of 4 patients who underwent a major resection for pancreatic cancer had life-threatening, potentially fatal complications associated with the big pancreatic cancer operations. Now that percentage is down to 2%. And so pancreatic cancer can be performed safely at major medical centers around the United States just because of these improved outcomes and techniques, because we've trained young surgeons to do the operations better, we've improved the techniques, but most importantly, we've improved the care of patients in the perioperative period. Better working with our anesthesiologists, better working with our intensivists, better working with our radiologists, better working with our gastroenterologists to treat complications. So we have greatly improved the outcomes for pancreatic surgery. As I mentioned before, the hospital mortality in the 60s and 70s, and if you're listening to this and you're interested in, as Wei Wu says, living to be 100, 60s and 70s, you remember those times. I mean, that was the Beatles and all the things that happened back in that time. They're still in some of our minds. But again, this perioperative mortality and morbidity of that time was horrible. And the survival we offered for our patients wasn't very good. And so people talked about, should we even have surgery, do surgery for pancreatic cancer? But fortunately, because of strong leadership from the generation that preceded me, the generation that trained me, surgeons have persisted and have made great improvement. And, I spoke earlier about the survival from the perioperative. The recovery from the operation is now less than 2%. That's as good as I think we're ever going to be able to get. But not only does it lead to better survival for the patients following surgery, but it leads to better survival on the long term for patients who have surgery. And the main key to that is having the right surgeon in the right hospital who has the high volume of pancreatic surgery to make them a safe institution. And again, if any of you and a family member are ever diagnosed with pancreatic cancer and are going to see a team that's going to talk about surgery and care, I think the important thing is to find out is that institution a high volume hospital or low volume hospital? And it translates into surgeons too, high volume surgeon versus low volume surgeons. Experience really matters, not just so much of the surgeon, but the entire team. And these are survival results for cancer at a high volume hospital. And you can see a highly significant improvement in survival at a high volume hospital. And you say, well, sure, those patients are more likely to survive their surgery. But even if they survive the surgery, it's still statistically significant. So again, I hope none of you or none of your family ever are diagnosed with pancreatic cancer. But please, if they are, you need to check out where you're being referred to make sure it's a hospital with experience, and experience really constitutes volume. And surgery has improved. There's many centers around the country, including ours at the MGH and at Johns Hopkins, where I will be working soon, where pancreatic cancer resections are now done robotically. And the data is a little hard to compare, but I think what's obvious is that the outcomes, usually shorter recovery, less blood loss, complications rates are about the same, but people who have robotic surgery tend to recover faster. If you recover faster, you're able to resume normal activity. And if there are further therapies that are going to be offered, it'd be more available with a quick recovery and a low complication rate than in someone who's had a prolonged recovery. So I'm not going to say robotic surgery is the total future for pancreatic cancer, but certainly cancers on the left side of the pancreas, robotic surgeries become almost routine. And for the right side of the pancreas or the head of the pancreas, again, in selected cases, the results are as good, if not better, than we can see with the traditional open surgery. So what is helping swing the pendulum in a better direction for people with pancreatic cancer? Well, first of all, we have better chemotherapy. 20, 30 years ago, the agents that we used for chemotherapy were single agent chemotherapeutic drugs of limited capacity to help. Now the therapies are all combination therapies that are significantly better. I've spoken about the optimization of surgical results, but if we're ever going to swing this pendulum, it's going to come down to early detection. And that's going to be my closing message to all of you. Now, screening for pancreatic cancer is we all talk about screening for breast cancer. We all talk about screening for colon cancer. We talk about screening for prostate cancer with the PSA test. United States Task Force on Preventive Services has not advocated screening for pancreatic cancer because there's moderate to high certainty that screening for pancreatic cancer has no benefits, and the harms might actually outweigh the potential results. But what they haven't been able to tell us is how to pick up those high-risk patients where screening is important. And I would say that even though we don't routinely do colonoscopies, we don't routinely do mammography equivalents for pancreatic cancer, in some cases we are. And there's hardly a patient who goes into the emergency room in any hospital in the United States who doesn't come away with a CT scan or an MRI scan. And there are very few primary care doctors who see a patient with any complaints who don't end up getting a imaging study, usually a CT scan, that will be used to detect lesions that we don't anticipate finding. And one of the things that Human Longevity does, as those of you who are clients know, that they do head-to-toe screening, and they do excellent screening. Now, the problem and why this screening isn't so valuable in large populations is that if you detect something, what do you do? And if you do something, does it involve an invasive procedure? And often an invasive procedure comes with risks. So this is where appropriate decision-making that might be guided by artificial intelligence, or, and I'm going to emphasize again, with genetic testing, who the patients are that really need this work to be done. So they say when you're talking about yourself, it's not a HIPAA violation. So 3 or 4 years ago, I was fortunate enough, my wife and I had the experience of going through the Human Longevity Program in San Diego. And not only was it one of the finest medical experiences I've ever had, but I was diagnosed with a pancreatic cyst. Now that's not pretty uncommon. It's not uncommon at all. Pancreatic cysts are one of the most frequently diagnosed findings on a scan that is done for another reason. So if you're in the emergency room, get a scan for trauma, get a scan for diverticulitis, appendicitis. If you're being screened for another cancer, whatever it is, you're going to get a CT scan. And if you look at least with respect to MRI scans, 15% of all MRI scans done in the United States will pick up a pancreatic cystic lesion. And if you're over 70, that percentage is up to 25%. Now, these are not cancer, but they are tumors. They are pre-malignant. And based on the characteristics of these cysts, they have a low risk of transformation into cancer. But again, 0.25% isn't zero. And it has led to many experts putting together guidelines to advise how patients who have these incidental findings of pancreatic cysts are followed. So it's been 4 years, I think, since I was in San Diego and had this test. Just a couple months ago, I had a follow-up MRI scan and my cyst has not grown and I feel comfortable. I don't need to have anything further done. But just like with Kim Eggleston and other people, when these pre-malignant lesions are detected, it gives us a chance, if they meet the certain risk criteria, to have an intervention. That intervention may just be a biopsy. That intervention may be surgery. The intervention, we hope moving forward, could be better judged and guided by genetic testing. I mentioned earlier that these cysts are extraordinarily common, and therefore groups have gotten together. 2 meetings that occurred, international experts in surgery and gastroenterology and oncology and radiology have gotten together on at least 3 occasions and provided guidelines as to who should have surgery. And again, fortunately, I'm in the category where my symptoms, none of these risk factors existed, and so I've been able to continue with follow-up. In 2012, we thought we learned a little bit more. The group got together and put together, again, high-risk stigmata, which mean these surgery patients should probably be offered surgery if their cysts have these criteria. And then worrisome features, which include cyst size, changes in the thickening or the nodules within the wall of the cyst, changes in the pancreatic duct. Any of these worrisome features that come together help us make a more intelligent decision as to who to recommend that surgery should be offered. And the problem is, and again, although I was stating that we made great progress, having a colonoscopy and having a polyp excised, having a mammogram and finding a small lesion that you can excise with a small biopsy. Those are certainly interventions that have some risk, but going in and taking out part of your pancreas comes with big risks. And those risks require a hospitalization of 5 to 7 days and risk of complications. And although mortality is very low, we do not want to offer surgery until we're absolutely certain that the risks of developing cancer or having cancer outweigh the risks of the procedure. And so this is what our job is. And again, where I do think the interface between genetic evaluation for patients in these high-risk categories is important compared to widespread screening across populations that we do for other more common cancers such as breast and colon. Now, I mentioned earlier we've made progress not only in the surgical side of it, but it's been significant progress in the treatment of advanced pancreatic cancer. I mentioned earlier the single agent therapies that existed going back into the 70s and 80s. In the 90s, we had a drug called gemcitabine. But in the last 2 decades, there's been a trial showing that the combination of therapies have really become the standard of care for patients with metastatic pancreatic cancer. And all you need to look at here is to see the difference between the solo drug therapy and the red line reflecting the better therapy, better outcomes that you saw with metastatic disease in patients who received the more advanced combination therapies. So the question became up, if these drugs work with people with advanced disease, who, as you can see, are almost all going to die, could we do better by applying these therapies earlier to patients with pancreatic cancer in the postoperative period before they have metastatic disease, or even preoperatively, as what we call neoadjuvant therapy, to shrink tumors to make them more amenable for surgery? So that concept of preoperative therapy is called neoadjuvant therapy. And it means you give the therapy before you do your surgery. And we've seen tremendous results in cancers such as esophageal cancer and rectal cancer, where neoadjuvant therapy can shrink the cancers and make them go away completely. And in those organs, which are easily accessible for visualization with endoscopy, maybe even avoid surgery. We haven't quite gotten to that point yet with surgery of the pancreas, because there's always still something there that you see on the CT scan. And so we end up doing surgery. But in the good news is that in now 7 or 8% of the patients with these therapies, these diseases can be completely eradicated with neoadjuvant therapy. So what are the advantages for neoadjuvant therapy? First of all, it selects the patients who recur early. Most adjuvant therapy regimens last 6 to 8 months. So if someone has advanced metastatic disease, it will probably blossom before one undergoes the major surgical resection. Number 2, and what I think is most important, is that after major pancreatic surgery, a lot of patients never are quite totally at the functional level of recovery that they can tolerate these therapies at the maximum doses. So if you believe in these chemotherapy agents, and you believe that getting the best and the strongest therapies is important, you ensure the patients can get that before surgery, because if they try to give it after surgery, up to 1/3 of patients may never be able to get the optimal treatment. So we may be denying 1/3 of our patients these optimal therapies by delaying the chemotherapy until after the surgical procedure. Then finally, and I mentioned the group of patients with about 25% of patients who have locally advanced disease that are involving arteries and veins that are not amenable to resection. We have found that by giving this therapy up front, that these tumors can shrink, they're more apt to be resectable. And by resectable, I don't mean just get it out, but get it out completely. Because for pancreatic cancer, an incomplete resection is a failed operation. And so to increase our chances of having a complete, as we call it, an R0 resection, there's plenty of evidence to say neoadjuvant therapy helps. Now, the arguments will be against it. We'll say that, has this been proven in widespread trials? No, it hasn't. And the reason it hasn't is because of the unintended biases that exist in terms of patients signing up for these therapies. And I think people either believe or they don't believe. And if they don't believe that neoadjuvant therapy is going to work, they're going to say you're just going to delay your surgery and the like. So we may never prove it, but I think the pendulum has swung to more people are favoring neoadjuvant therapy for patients with pancreatic cancer than ever before. And so much for missing the window of opportunity for some patients. Again, having for now close to 15 years of treating patients with the high percentage of getting neoadjuvant therapy, the number of patients who I've seen actually advance during the therapy between the diagnosis and surgery while getting chemotherapy is a very small percentage. So I think very few people are missing that window of opportunity. And more importantly, when they get that window opens that they're optimized for surgery. But as I said, everything I've spoken of so far has been things that we've done in the last 20, 30 years to improve the outcomes. But the future really will be improved by early detection. And our methods for early detection are very vague. Now, this is a lay publication that I don't want to burst any bubbles, but I am a member of AARP, and I'm not going to credit them for a disservice in what they publish. But I read an article in AARP, and they describe 6 or 7 warning signs of pancreatic cancer. Abdominal discomfort, and your abdomen radiating into your back. New onset diabetes or worsening blood sugars. Dark urine, light stools, jaundice, itching, fatigue, loss of appetite, weight loss. None of these are early signs. If you have any of these signs, you likely have an advanced pancreatic cancer at the time that you're diagnosed. And so we can't count on your traditional history and physical examination to make a difference in early detection for pancreatic cancer. Well, what about imaging? I spoke earlier about the widespread use of CT scan and MRI for patients who come to the emergency room with other diagnoses. And yes, we celebrate when we find one of these patients and we intervene and resect or identify and eliminate the lesion when it is precancerous. And again, if Kim was willing to share his video at the beginning of this, Kim Eggleston had a pre-malignant lesion that, as he said, had it not been detected through the radiologic imaging of human longevity, he would never have been diagnosed until it might have been on that last slide with all those other symptoms. But that didn't happen because he had the imaging. And we just have to be smarter in terms of how we apply this widespread imaging. Every week at the Mass General Hospital, we have a group of surgeons and radiologists and gastroenterologists to get together and review somewhere between 25 and 40 new patients a week that had an x-ray for another reason, who had an image that showed something that's suspicious and needed further evaluation. Not surgery, maybe not even a biopsy, but to define a treatment plan and follow up so that these do not develop into cancer. And some of them obviously require more and some require less. I happen to be in the group that require continued follow-up. Other people, and Kim fell into that example of someone who would benefit by, first of all, the endoscopic ultrasound, which guided our decision-making, and then ultimately surgery. Endoscopic ultrasound is by far the most sensitive technique for picking up small lesions in the pancreas and doing testing, which consists of biopsy or aspiration of fluid that can guide our decision making. In some cases, can diagnose the lesion as being precancerous to the point where we need to do surgery. But again, it requires a general anesthesia. We cannot do that on a widespread population. So we need to apply that to specific groups that are defined by some other testing mechanism. I spoke earlier about a tumor marker of CA19-9. It is a very valuable tumor marker. We use it every day in the care of patients with pancreatic cancer, but it is not a diagnostic screening test. It is not a test like, most of you go to your primary care doctor. I would assume Human Longevity offers the PSA test. My primary care doctor asked me, do I want it? Because if you get it, sometimes it leads to other things that people don't want to have for prostate cancer, other tests and biopsies. So, but CA19-9 is not valuable as a screening mechanism for wide population. So this opens the door for genetic screening. And here's my punchline. And again, I am not a molecular biologist. I'm not a molecular geneticist. And the studies that are being done that are going to guide the future of early detection and identifications of pancreatic cancer are tests that are being done in the laboratories around the country now to detect either from a blood-based test or perhaps in people who undergo a fluid aspiration, identification from the fluid of various epigenetic and genomic profiles that will define a inclination that they have to develop cancer. And again, I'm a little ahead of my skis here, but Human Longevity is now partnered with a company that provides this testing for a DNA modification known as 5-hydroxymethylcytosine, which has been tested to show as a sensitive biomarker of the changes that are present in the earliest stages of pancreatic cancer. And in a study of 2,000 samples, they demonstrated a high specificity. That means if it's positive, it means something. But more importantly, it's sensitive in that it is able to detect a high percentage of people too. So you want to test, of course, with high specificity and high sensitivity, because when it's positive, and when it's and it's not going to be wrong, but it's not going to miss many things. By leveraging these signals, this test enables earlier and more accurate detection of pancreatic cancer when interventions are most effective. Now, I have not personally had experience with this. Wei Wu and his team and I have talked about, should we apply this to the patients who have IPMN? Should we take a population already at risk? Should we take a population of patients who have a family member or two family members and apply this test widely? But again, if you're a client of Human Longevity, like I am, and you see the opportunity that you can be screened, and particularly if you have a low risk but still potentially malignant lesion like I am, I think you might sleep better at night than having this test. So that's really the end of my talk. I certainly left plenty of time for questions, and I'll turn it back to Wei Wu to lead the discussion.
Great. Thank you so much, Dr. Lillemoe. This is such a wonderful presentation, and you just give me more confidence that together we can really improve the survival of pancreatic cancer, which actually kills more people in the U.S. than prostate cancer. Although prostate cancer is much more, has more incidence, but the death rate is actually smaller than pancreatic cancer.
And same for breast, and same for colon.
Yeah, exactly. So I have a few questions from our audience. Cancer rate diagnosed among young people. Any thoughts on why a sudden rise in pancreatic cancer rates diagnosed among young people, less than 50?
I think part of it is earlier diagnosis with testing that's made available. I think it's still a disease that people in the 60s and 70s and 80s are the predominant group. But, I think it used to be when somebody with pancreatic cancer, somebody was young, would have abdominal pain or symptoms of any kind, or new onset diabetes. People just said, oh, it can't be cancer. I think the threshold we now have to screen people younger is greater. So clearly there is of shifting that way, but I think it's just a better awareness of that it is a diagnosis and people are being screened or evaluated quicker than they may have been in the past.
Yeah, interesting. But I was actually at Mass General talking to Dr. Danieli, right? So she actually operates on a lot of the pediatric cancer patients. She does observe, at least at Mass General, there are younger and younger kids getting cancer. So, it's probably a lot of, gas we can add it on. Maybe,
There's a specific type of tumor. I think you were talking about Dr. Danielle Cameron.
yeah,
And there is a specific type of pancreatic tumor that we do see in young women,
Yeah.
even in their teens and early 20s, that we see. And again, there's a type of these mucinous cystic. I've talked about the IPMNs, but there is a class of cystic tumors of the pancreas that we see in young women too. So there is, particularly for women, some diagnoses of higher risks situations that, again, earlier diagnosis and earlier detection can make a difference.
Yeah. The next question is from Dr. Eric Dinnenberg, one of HLI's physician. Wei, can you post that the question? If a client has a stable pancreatic cyst, okay, here's a question. So if a client has a stable pancreatic cyst and also a genetic risk for pancreatic cancer, would you recommend this client to do Avon-Tech pancreatic liquid biopsy annually or every 6 months? Or would you recommend a different approach for surveillance?
Well, certainly, if you have a pancreatic cyst that has been identified and you have the risk factor of a family member, you absolutely should have the screening test. Now, I'm just going to show my ignorance here. I don't know if it's something that evolves. I mean, if you get one test and it says your risk is now 0 based on the data that you shared, I don't know whether it's 6 months or a year or 2 years or how often you need to do it. And I bet that question hasn't been answered. But the one thing I would say, if you have a cyst, you have a genetic risk, you better darn well get this test done.
Yeah. And also you can probably do more contrast MRI and all that. We will recommend high-risk client in our clinic to do contrast MRI. And because our annual physical doesn't do contrast MRI, we only do regular MRI. So, and based on what I know about the Avon-Tech test, the negative predictive value for stage 1, stage 2 is 99.6%. So if the tests come out negative, you probably can sleep well. I will sleep well if I come up with a test which is 99.6% negative predictive value. Basically, they say I'm negative. I'm 99.6% negative.
But the question is if you're 55 years old, how many years can you sleep well?
Well, I would do probably contrast MRI for, maybe every 6 months just to see if it grows. If it doesn't grow for 2 or 3 years, I probably will sleep really well.
Yeah, well, that's kind of how we do it too.
Yeah, right. So yeah.
But I would say when this test is widely available, it's going to change the way we manage people with pancreatic cystic lesions.
Yeah.
Particularly those who have those criteria that I said are high risk or suspicious lesions.
Yeah.
Because right now, the best we can do is do a test that is, again, doesn't have the greatest sensitivity, and that's the endoscopic ultrasound and aspiration based on cytology. Now, there are also experts working on looking at the cyst fluid to see what the genetics of that cyst fluid is. And to us in surgery, the holy grail that we're seeking in pancreas, a test either from the blood or from the cyst that can say you need surgery now or you will never need surgery.
Yeah.
And because, again, if you're diagnosed at 55 with one of these cysts, you want to have an MRI for the next 40 years until you're 90 years old. I'm not sure. There is some cost effectiveness here. And
so this is why a blood test, probably, a low cost blood test ultimately will be we are pushing for obviously proteomic marker. So not instead of one marker, you are doing maybe 2 or 3 dozen markers.
Absolutely. Again, when you do your full workup, if this is just part of the panel, it's very reassuring.
Yeah.
And again, it's a blood draw. It has nothing to do with a procedure that requires general anesthesia.
Yeah, exactly. So we have another question from Madison. Do you think there's any utility in using CA19-9 for screening?
Not for the general population.
Yeah.
First of all, only about 80% of people have a blood type that allows this antigen to be even expressed. So even in the best, it's going to miss the diagnosis in 20% of people. And still, it just is not sensitive enough at the lower levels to help in a general population. Where it's most valuable is as something when you diagnose with pancreatic cancer, you know what the CA19 is, and it helps guide therapy and it helps guide a recurrence.
Yeah. Next question is from In. How much hope do you have in neoadjuvant therapy for someone in their late 50s who has already been diagnosed with late-stage advanced pancreatic cancer?
So, first of all, late 50s is young. So, number one, when I see somebody in their 50s or 60s, I want to load them up with neoadjuvant therapy because I know they will tolerate it better than somebody in their late 70s or 80s. Now, where the question mark comes in is late stage advanced pancreatic cancer. If it's locally advanced, yes, that's what it's designed to work best on. If it's stage 4 disease with metastatic disease already, and again, if we confine late stage to non-stage 4 disease, that's where the best results have been seen, and there's been plenty of trials to show that it is effective. And the younger you are, the better, the healthier you are, the better you'll tolerate it, the better your results will be. And again, it's in that population where we've seen population of patients in 7 or 8% who have a complete response. If you define late stage as people with multiple metastasis in their liver, it's not really neoadjuvant therapy in that situation because most of the time that's considered therapy for stage 4 disease.
I would really recommend you to look into the mRNA vaccine result recently. I believe it's BioNTech. They released a late stage mRNA vaccine for late stage pancreatic cancer. I think the placebo group only lived about 3-4 months, but the vaccinated group lived to 15 months for a small cohort. But I think it's very encouraging.
Yeah.
Yeah.
But that's not neoadjuvant.
That's not neoadjuvant. It's an mRNA vaccine. Yeah.
But
personalized.
If those results work in the advanced stage, the next thing they might be applying it to neoadjuvant therapy.
Exactly. And add a little bit PD-1 when you vaccinate the patient. Add a little bit PD-1. I love to see that the result of that trial. So yeah, because if you express the neoantigen and your T cell goes to work, and if you even add PD-1, your T cell will probably become more aggressive in some, so I love to see that study. Yeah. And next one is we have been, there's this one. Okay. So Dr. Keon, great talk. As clinician in the field that is aggressively screening asymptomatic patients, we at HRI sometimes find that outside specialists dismiss some of our tests like AVONTech. So are there things that you would say would be clear triggers for a specialist to do, at least consider seriously doing an EUS biopsy?
Absolutely. If somebody has a cyst that's detected, no matter what size or other risk factors come up, and the Aventec screen is positive, I would say I would encourage that patient to undergo an endoscopic ultrasound and aspiration of the fluid.
The good thing about the Aventec test, it's not like we're promoting them. We're just using them as another tool. It's just a blood draw, right? I mean, the side effect of that is extremely minimal. So, and as volume increases, I guarantee you that the price will drop for a blood test. Yeah. So, yeah. Okay. Yeah. Do you prevent the screen? That is, we kind
This
of
gets into, again, the question about CA 19-9 as a biomarker. Again, I do not believe it has any role in preventive screening.
Yeah, it's
and again, if your pancreas normal on CT or MRI, and you have a family history, then I'd probably do an endoscopic ultrasound. But I'm certainly not going to take out somebody's pancreas based on a high CA 19-9 if there's no lesion seen.
Yeah, yeah. So if, I have been developing diagnostics for God knows 40 some years, and FDA will never approve a screening test. The positive predictive value is less than 10%. So CA 19-9, if I remember correctly, is not even close to
No,
6.
it's not.
Yeah, so
Not in a widespread population. Absolutely.
yeah, that's right. Yeah. So yeah. Okay. So okay, another one from our clinician. Well, you get a lot of attention from our clinician, so that's great. Julia's question is: besides maintaining a healthy weight, not drinking a lot of alcohol, not smoking, are there any other lifestyle modifications a patient can make in order to decrease their risk of pancreatic cancer?
I think the things you said, weight, alcohol, smoking, they can help you with heart disease. They can help you with diabetes. They can help you with vascular disease, cerebral vascular disease. And if pancreatic cancer goes along for the ride, I think the obesity, I think, is clearly a risk factor. Alcohol in moderation is okay. It's really people with chronic pancreatitis from alcohol or familial reasons are the ones at risk. I don't know much else that one can do other than the things that you have there.
Yeah.
Great question here. What's a family member? We call it first degree relatives. Means mother, father, sister, brother, or child. So usually, typically, what we have is somebody comes to see me, they're diagnosed with pancreatic cancer, and they have a family member who had it, and say a brother or a father and an uncle, I would say their family should be screened for pancreatic cancer with imaging to begin with, and maybe even endoscopic ultrasound. 2 first-degree relatives, brother, sister, mother, father, or sibling.
Yeah.
The answer is no. I was at Human Longevity a couple of, I guess it's probably been 3 or 4 years. I have not been back. My cyst is stable. It's small. It's less than 1 centimeter in size. Again, it's not what I would consider high risk, and I have no family history. But if it grew, or if I had a family history, I'd absolutely have the test.
We can always send a nurse to your home to collect the blood. Okay, so you don't have to be here. Okay. Yeah.
But literally, I mean, Wei Wu and I have only been talking about this test now for 6 months, so it's still new onto the.
Yeah, we are gaining more and more experience with the test.
Yeah.
Yeah, and it's a learning process. this is why I am hopeful, because there's so many new solutions coming out. And I think the AI in the future is going to be amazing, because when you combine genetics, liquid biopsy, protein marker, imaging, I think the AI will, with outcome data, the AI will improve the accuracy more and more. There's really no doubt in my mind that the AI algorithm will continue to improve the accuracy of diagnosis. So, what are your thoughts on the quality and accuracy of GRIL test, especially for early detection of pancreatic cancer?
I'm going to show my ignorance. I'm not familiar with that test.
Okay, yeah.
I think I've kind of answered that question. I'm not a favor of, oh, I'm sorry, this is CEA. CEA is specifically associated with colon cancer. It is a secondary blood screening test that we use for pancreatic cancer. Frankly, even people with advanced pancreatic cancer, I don't find it very valuable. I certainly don't find it valuable as a screening test for pancreatic cancer alone. So no, I don't think, I think if somebody comes in with a cyst, has some risk factors, I think it is CA 19-9 and CA are useful, but not as a widespread screening test for asymptomatic patients with no detected lesions.
Well, here's, just a little bit anecdote. I worked with Dr. Robert Bast, for a while. I consider him as a friend. He's at Mass General, actually, believe it or not, as a resident, he discovered CA125 for ovarian cancer. But CA125 was never approved by FDA as a screening test for ovarian cancer, as a single data point, because the positive predictive value is less than 10%. But lately, they did a huge trial in UK by looking at CA125 changes, a longitudinal data on women. The positive predictive value becomes, I think it's close to 10%. So actually, if you look at a CA125 delta change on annual basis, it becomes much more predictive. So some of these biomarkers, this is why we believe in longitudinal data set, because if that number, is low in some client, but they keep going up every year, it's actually more predictive of, there's underlying some pathology, because some marker is changing fast, right? So yeah. Where you want to show more questions?
That's all the questions.
Okay, so we want to be respective of, and if anybody has more question, shoot an email to Human Longevity, and we'll pass to Dr. Lillemoe. Thank you so much, Dr. Lillemoe. Actually, we will work together in the next 10, 20 years to eradicate this disease, okay?
All right.
Yeah.
Thanks, everyone, and
Thank
appreciate
you.
your time. Have a good evening.
Yeah. Okay, thank you. Bye-bye.
Thank you.